Hey guys, can you hear me? See me? Hello. Am I audible, visible? Hi Rishi, that's great. Hello Shad. Okay. So guys, welcome back once again. So we will be starting about GIT. Supposedly I should also take liver, but there is an emergency, so I would like to do GIT today, and I'll be taking liver along with the female genital tract and breast tomorrow. Fine. Okay. So our entire focus is going to be on GIT today. Good evening, Ashley. Good evening, Srimati. Good evening, Rishi, and good evening, Arshad. So we will do the same thing. First, a couple of scenarios. I want you to tell me the diagnosis that I'm not interested in. I want you to tell me the clinical data points which are led to the diagnosis. Like that, we'll go for a couple of them, and then we'll start having a template and quickly revise a few important topics with respect to GIT. Fine. Ready? If ready, do let me know what is the diagnosis and what do you think is the clinical pointers which led to the diagnosis. Come on, fastest finger first. Good evening, everyone. Good evening. Duodenal ulcer, great. Duodenal ulcer. Why it's not gastric ulcer? Come on, a diagnosis you guys know, right? I'm not coming to the diagnosis at all. I know that you're experts in diagnosis by the time, right? Why? First, my history. History is going to be a burning pain. See, the term burning is important because if you have read about the characters of pain, burning pain is something which is always related with an ulcerative episodes, right? So burning pain is very, very important, right? And which often wakes up in the night if that is required or not. But like Snehajit said, the pain being relieved after eating or drinking milk, right? So that's very, very important, right? The pain reduced after food, whatever food it may be, milk or water or any food, that's very, very important. Epigastric pain, epigastric tenderness kind of may be common for both gastric and duodenal ulcer, but this tells me yes, it's probably a duodenal ulcer, right? So I can write as duodenal ulcer, or you can just use the term peptic ulcer disease, PUD. That also is good enough because peptic ulcer disease, the common cause is obviously is going to be duodenal ulcer only, right? Perfect, great. Night pain is more common in duodenal ulcer. With food is common in duodenal ulcer as well, right? Gastric ulcer, duodenal ulcer is definitely the most common cause. Gastric ulcer comes a little bit less than duodenal ulcer in terms of incidence. Fine. Okay, let's go to the next one. There is a bit of a different history here. Let's see how we are going to take it. Can anyone tell me the diagnosis? Whatever comes to mind. Diagnosis one side, but what I want is the approach to the diagnosis. We'll write the diagnosis, obviously. And what do you think is the clinical data points which has led to the diagnosis? Anyone? Okay. A patient complains of early satiety, a vague abdomen, varicose of esophagus. Let's come to it. A vague abdomen fullness after meals and an unintentional weight loss, right? This they also have occasional bouts of nausea and sensation of something stuck when swallowing solids, right? This is kind of a misleading thing, but it is important for us to understand that as well. Fine. Okay, Pramod has gone to a very characteristic finding. Let's see if that is right or not. Achalasia cardia, upper abdomen fullness. Fine. There's mild pallor, abdomen soft with no palpable mass, right? So I want to highlight only one part here. Can anyone tell me what does this indicate? Esophageal viruses will not have an unintentional weight loss, right? It won't. Neither is will achalasia cardia. Achalasia cardia might fit into the bouts of vomiting. That definitely it will, right? And a GERD also will not cause an unintentional weight loss, right? A significant weight loss is losing 10% of the body weight in 6 months, which almost always indicates only one person. Fine. Okay. Okay. Something stuck when swallowing. It's kind of something which is blocking the way of the passage of food, which could be, this could be a classical finding with respect to your esophageal tumors, with respect to your gastric tumors. Okay, with both respect to esophageal and gastric tumors, that will be there, right? And patient has an appetite and there's an early satiety. See, early satiety is a symptom, and explaining stuck when swallowing solids is also a different way of explaining, okay, it's full, something is stuck between, it's full, right? And upper abdomen fullness, again, it's moving more towards a gastric problem, and unintentional weight loss definitely tells me it's a malignancy, right? So most probable diagnosis, like Pramod said, I would say gastric or an esophageal cancer, right? But I would more prefer a gastric cancer because of the early satiety, unintentional weight loss, which is very, very classical of diffuse gastric carcinoma. You need not pinpoint to write diffuse gastric carcinoma, but if you can say gastric adenocarcinoma, that should be more than enough, right? The anorexia, linitis plastica, that's very, very classical, but it's not required to go with that much amount of certainty. But if you say gastric adenocarcinoma or an esophageal adenocarcinoma, in other words, an upper GI malignancy will be a very apt diagnosis clinically. I would want more investigations and more history to tell whether it's esophageal or gastric, right? So clinical clue, the most important clue here is a weight loss. See, loss of weight, loss of appetite is something which will be very, very, very common in every cancer history which comes to you. Please look into that, right? And unintentional weight loss, and the patient has early satiety and the feeling of stuck feeling, right? Something is blocking reaching. That's what the stuck feeling means. Fine. That's a classical description taken from Bailey and Love. When you go to surgery books, you'll definitely read about them, right? Hi, Pratham. Okay, let's go next one. Let's see if you guys can pick this up. No. Early satiety is not the reason for the unintentional weight loss. Unintentional weight loss should most likely be the terminal stage of the gastric malignancy or any malignancy for that matter, right? Early satiety because of the linitis plastica, not able to expand. That's the reason you have the early satiety. You can fit both, but I would prefer incidence-wise, gastric adenocarcinoma is a little bit more common than esophageal. Unintentional weight losses, like I want to lose weight. I go on a extremes of this intermittent fasting. I might still lose weight. I don't want to lose weight, but then also I'm losing weight. That's unintentional weight loss. No, Rishang, I'll be covering only GIT today. I'll take liver and FGT and breast tomorrow. Fine. I'll also come. I have to go a little bit early today. I'll try to cover GIT today. Fine. Diagnosis. A patient has chronic intermittent diarrhea, bulky, pale, foul-smelling stools, reports of bloating and fatigue. Malai Vanakam Vijay. Lost weight despite normal appetite. Okay. Mild wasting of thenar eminence, scattered bruises on the limb. Pramod, okay. One direction is fine. IBD, okay. See, first of all, things you were confused with IBD. One important thing about IBD is it should have diarrhea with blood and mucus. Please look for this for IBD. That's a very, very classical symptom of IBD. Feeling of wanted to pass stools. That's called tenesmus, but stool is not coming out, right? That's a very, very classical feature of IBD. So it's not a feature of an IBD, right? Why thenar eminence is not prominent and scattered bruises on the limbs? Okay. Chronic intermittent diarrhea with bulky, pale, foul-smelling stools, reports of bloating and fatigue, right? Perfect. One thing which you're sure about this is, can I say all these symptoms of malabsorption? I'm not going to the extent what Pramod said of to call it an pancreatic problem. Can I say it's malabsorption? That's fine. Okay, perfect. Lost weight despite having normal appetite, right? One history is not being given here. That is actually the most important clue. If I give you the history, you guys will definitely tell the exact diagnosis. All these incidences happened after consuming chapati, roti. What will be the diagnosis? Yes. So scattered bruises on the limbs and muscle wasting are also parts of one more thing, person, dermatitis herpetiformis. Right? Great, Rishi. Yes. Diarrhea with blood is dysentery only, but generally the explanation will be given as diarrhea with blood and mucus because dysentery is more of a technical terminology, right? History will be blood and mucus. Okay, perfect. So this combination. And one history which is missing here is you must have had the history of after consuming the bro foods. There's malabsorption, there's skin problem, there is skin and muscle wasting. All these are classical of an celiac disease. Your diagnosis here is a classical finding of an celiac disease. Okay, so we've got many differential diagnoses here, right? So let's go and look into the other differential diagnoses also here, fine? Okay, so first thing what we got is liver cirrhosis is not going to fit into this, so I'm not going to liver cirrhosis here, right? Why could not it be an obstructive lesion in the liver, right? So Pramod said it could be an obstructive lesion in the liver. One of the most important thing in obstructive lesion in the liver is you should have jaundice, it should be there, plus pruritus. That's very, very, very classical of any obstructive lesion of the liver. So it's unlikely to be an obstructive lesion of the liver, right? IBD, again, already discussed. It should be diarrhea with blood and mucus or dysentery. That's very, very, very classical, fine. Celiac also has problems. See, malabsorption, right? Protein also will be difficult. So the eminences, it's not exactly thinner eminence. It's muscle wasting in general, okay? Whipples. Why it is not a Whipple? Whipple is a very good thing. I think you guys went to Whipple only when I pointed out malabsorption. But Whipple is also always a multi-system thing. And Whipple is an infection. Without fever, Whipple can never happen, right? So when you have fever with malabsorption diarrhea, and the most important thing with Whipple is it's not limited to the gut. You'll have joint involvement, arthritis, you'll have cardiac involvement, right? You have neurological involvement. Whipple is a multi-system disease, presents with the diarrhea, right? So all these are classical of a Whipple's disease, fine. So Whipple, obstructive jaundice, we had differential diagnosis here. We had IBD differential diagnosis here. If any of these three comes, get used to it. The only thing which was intentionally taken out from the history is bro foods. But don't worry, in a long answer question exam, they will give bro foods. But I just want you to remember, whenever there's in bulky pale form stools, I'm talking about malabsorption, always have those in the differential diagnosis, not something else, fine. Arnav, you'll have lots of time. Join us and let's enjoy medicine, okay? Got it, Pramod, fine, perfect. So let's go to the same template. The template is not going to change here. The template is same. We'll have the definition, the etiopathogenesis, clinical features, gross microscopy, IHC if it's a cancer, complication or outcome based on the disease. Let's take it out, right? If it's a malignancy, let's end it with prognosis and little bit word about the treatment. Like it's a gastric tumor, gastrectomy along with chemotherapy plus prognosis poor or good, decent prognosis, fine? Okay. So what we're going to see today's lecture is, we'll talk about gastric cancer. Anish, giardiasis is a malabsorption diarrhea, right? Giardiasis will not be recurrent. Few things which is not giardiasis will not be recurrent. Giardiasis will not have any problems in the skin, but yes, giardia also can present like this. I am not denying that at all. Fine. Okay, let's come back to this. We'll be looking at gastric cancer, we'll be looking at colonic cancer, we'll be looking at IBD, we'll be looking at peptic ulcer disease. These four are things which I feel at least one of them might come in a long or a short answer, and we should be able to write about that. Fine. Okay. So gastric cancer. So gastric cancer, the risk factors or the etiology. Write both. Please remember, we have two types of gastric cancer. Can anyone tell me what are the different types of gastric cancer? We have the CDH1 mutated, which is your diffuse gastric carcinoma. The other one is your intestinal type gastric adenocarcinoma. Actually, intestinal type gastric adenocarcinoma will have FAP mutation. Diffuse type gastric adenocarcinoma will have CDH1 mutation. And these are sporadic thing. For any cancer, I have the same template. You need not add on to anything. Same etiopathogenesis, sporadic syndromic. Then go with the clinical features. Then go with the microscopy, gross and IHC. That's it. Fine. So H. pylori gastritis is one of the most important thing, and this is going to cause more increase in favor of your intestinal type adenocarcinoma. And a HNPC also will increase the risk of intestinal type gastric adenocarcinomas. Fine. The Lauren classification. And this will cause your diffuse type of gastric adenocarcinomas. Fine. Chronic gastritis could be due to any cause. Autoimmune gastritis or an H. pylori gastritis, as mentioned above, can result in it. Partial gastrectomy, because of the bile reflux, what's going to happen? There'll be more amount of inflammation, because bile in the gastric mucosa will definitely cause inflammation. This inflammation will increase the free reactive oxygen species, which might increase the risk of your mutation, which might cause the carcinoma. That's how it is. And nitrates being or smoked food, they are directly carcinogens. They also can cause mutations, right? So risk factor, we divide them into sporadic and syndromic. Let's come to the pathogenesis. See, if it's a long answer, write the pathogenesis separately for your diffuse type and for your intestinal type. If it's a short answer, write that, fine. Okay. Yeah, FAP will also cause it, right? It should be ideally FAP, not HNPCC. Ignore this. My bad, right? Familial adenomatous polyposis is the one which causes that, fine. That increases risk of both gastric as well as your colonic adenocarcinoma, fine. So when you look at the pathogenesis for an intestinal type gastric adenocarcinoma, you can have your H. pylori or any carcinogen that will increase the risk of mutation primarily due to your reactive oxygen species or the carcinogen itself, right? And that most likely causes mutation in your APC beta-catenin pathway. Most of the intestinal type gastric adenocarcinoma will cause APC beta-catenin mutation only, and that APC mutation or a APC loss of function mutation or a beta-catenin gain of function mutation is going to result in increase in cell division, which causes carcinoma. Or I can have the syndrome part of FAP where APC mutation is inherited. That can also increase the risk of your syndromic gastric intestinal type gastric adenocarcinoma, right? That's one side. The other side, what we have is your diffuse type of gastric adenocarcinoma. Diffuse type gastric adenocarcinoma predominantly happens only due to mutation, and that's your CDH1 loss. So in CDH1 loss, the CDH normal function is E-cadherin synthesis. So when there's a loss of CDH, there's reduced E-cadherin in loss of function mutation. Reduced E-cadherin does two things. One, obviously, it will not let it bind properly, right? Great, Vijay. Read well. One, there'll be less cell addition because less cell addition does not cause a cancer. Please do remember, you also have to write the most important thing is loss of contact inhibition of growth. This word is very, very important whenever you're going to write the pathogenesis related to CDH1. Okay. Loss of contact inhibition. When the contact is lost, I will not be able to know there's one more cell here. That will increase the cell division, right? So this loss of contact inhibition is the one which increases the cell division. Not just increase cell division, plus easy spread. Okay. That is characteristic of your CDH1 related diffuse gastric adenocarcinoma, right? Same pathogenesis I want you to write for your lobular carcinoma of breast when you go to breast pathology, right? Because same CDH only. Loss of contact inhibition, reduce cell addition, and it can spread easily and will not produce a very well-defined mass, fine? So we know about pathogens for intestinal and pathogens for diffuse as well. Symptomatology. So symptomatology for an intestinal adenocarcinoma, it's most likely like a long-standing peptic ulcer. You'll have this because this also is an ulcer, right? It's a malignant ulcer, that's all. But ultimately, it's an ulcer, right? So history will be extremes of like recurrent stomach upset or recurrent epigastric pain, plus or minus melena, could be the long-standing history. In addition to that, what differentiates it from a benign from a malignant ulcer is you'll have loss of weight and loss of appetite. That will be there. And in extremes or in very late cases, which might cause a gastric outlet obstruction. So gastric outlet obstruction can result in vomiting and nausea. That will obviously happen in the late case only, because the food will not be able to pass to the duodenum, right? These are the things, right? Ulceroproliferative, which is for gross. We'll come to the history, then we'll go to the gross. Loss of appetite, loss of weight is always in the advanced stage, right? So I wanted to add here, if it's a diffuse type of gastric adenocarcinoma, in addition to this, the most important characteristic feature is early satiety. Early satiety because, like you guys said, the leather bottle appearance. Its lineatis plastica, it cannot expand, it's stuck. So I'll have an early satiety. That's a very, very classical finding for a diffuse adenocarcinoma, right? So metastasis related, these terms are important because this might come in a viva, right? What's Trousseau's sign? Anyone? Umbilical nodule, you have your Sister Mary Joseph nodule. What is Trousseau's sign? You might go and have a look at Trocheus sign even when you are going to surgery. It's also a clue for metastasis. I want you to tell what metastasis it is. There are multiple Trochea we have read. One we read in neoplasia as your migrating thrombophlebitis. That's a different Trochea. Trochea sign is otherwise also called as virtuous node. I'll leave it at virtuous node. I want you to tell what is virtuous node. Perfect. Like Snehit said, a left supraclavicular lymph node involvement. Okay. A left supraclavicular lymph node involvement is also required. Rishank, that is an acquired mutation. Here it is the cause. We have discussed this multiple times. In diffuse gastric adenocarcinoma, loss of E cadherin is a driver mutation. In every metastasis, loss of E cadherin is a passenger mutation. Fine, that's a difference here. Fine. Okay. Great. Perfect. Fine. In addition to that, one more thing about metastasis, a diffuse gastric carcinoma can undergo mets to ovary, which can cause a bilateral involvement of the ovary, which can also present as an Krukenberg's tumor. Okay, so there are different modalities by which a gastric adenoma carcinoma can present, primarily due to the tumor or due to the stage of the disease, loss of appetite and loss of weight, or due to the metastasis. All these can be the presentation of gastric adenocarcinomas, and these are worthwhile in a viva. In a real life, gastric adenocarcinoma presenting as Krukenberg is very, very rare. Left supraclavicular lymph node might be common, but other things are a bit rare. But for an MCQ or for a viva, they might generally go for the rarest findings for you to test, right? Okay, let's go to the gross. Gross sites. So sites, the most common by default is your intestinal type of gastric adenocarcinoma. Okay, the most common sites are your pyloric antrum, then the lesser curvature. For a diffuse type of adenocarcinoma, I don't have a common site, right? So what I'll be seeing in the gross is two types. One, I can see in, like you guys said in this first time, ulcero-proliferative lesion, which will classically present as a malignant ulcer. Okay, so can anyone tell me what are the components of malignant ulcer? Second one, I'll have linitis plastica. Okay, so the linitis plastica in one, and you'll have an ulcero-proliferative malignant ulcer in the second, right? So what are the features of a malignant gastric ulcer? Malignant gastric ulcer features. They are an exophytic or an ulcerated mass where you will have the most important finding, you'll have heaped up margins, right? They'll have an ulcer with heaped up margins, right? The base will not be clear as opposed to a benign gastric ulcer, and there'll be no radiating mucosa from the edge of the ulcer. Okay, and most of them, they are more than 2 centimeter in size. A benign peptic ulcer are generally smaller, right? So these are the important things. Heaped up margin is very, very important for me to say it's a malignant ulcer, right? Microscopy will go to the dysplasia and invasion and everything, fine? Both are ulcerative. See, the ulcer is nothing but breach in the normal epithelium, right? Something is growing very fast from here. Do you think it will let the normal surface be normal? It won't. It will grow and it will destroy, right? That's how it will be predominantly, fine? Perfect. So if you want to draw a malignant ulcer diagram, one thing which will be interested is the heaped up margin. You can say that this is the flat normal surface, and I can explain the heaped up margin of an ulcer, and this is the base of the ulcer, right? Okay, if you're artistic, draw the non-radiating rugosity also, but here at least the heaped up margin I want you to know to explain in while drawing an malignant gastric ulcer, right? And linitis plastica, or the leather bottle appearance, it's nothing but the entire wall of the stomach will be thick. Okay, so it will be like a leather bottle. We have seen linitis plastica. If you want to draw linitis plastica, the same stomach, the only thing is extremely thick wall. An extremely thick wall, that's diagnostic of an linitis plastica. Fine. And Linitis plastica, when you look in the endoscopy, there will be flattened rugosities on endoscopy. That is also a gross finding. You won't see rugosities at all because underlying there's lots of desmoplasia happening, right? Because endoscopy is the primary way by which I can put in a tube and look at the tumor and take a biopsy, fine? So these are the two gross types, also proliferative type and the Linitis plastica are the diffuse type, right? So coming to microscopy is very simple. Again, it's going to be based on two types only. So the interstellar type and the diffuse type. You can write here the classification, the Lauren or the modified Lauren classification, or you can use the term WHO as well. WHO is also based on Lauren's classification only. Have intestinal type of gastric adenocarcinoma, where it's glands, dysplastic glands. I'll have all the four features of dysplasia: pleomorphism, high NC ratio, mitosis, loss of polarity, and obviously I'll have invasion. Invasion, the next layer to the epithelium is invasion at least into your lamina propria. Okay, that is enough for us to say it's an intestinal type of gastric adenocarcinoma. And diffuse type. So do you guys see glands in case of diffuse type, or there'll be no glands? In your diffuse type, Rusha, if your question is on diffuse type, they don't destroy the rugosity. Ruga is folding, right? Underneath there is fibrosis, desmoplasia. So the folding becomes flattened, that's all. Okay. So a diffuse type, there'll be no glands, no ducts. That's the most important thing. And the only thing I'll be saying is Zygote ring cells. Zygote ring cells are characteristic of a diffuse type of gastric adenocarcinoma, fine? Okay. Okay. So see, drawing a diagram for intestinal and diffuse type is pretty simple. Put a box. Zygote ring, I am sure you will be able to easily draw. Put oval cells and nucleus in the corner. That's all. And maybe if you want to put some pink background indicating there is desmoplasia. Intestinal type, again, a very ill-formed glands lined by ugly looking cells. And you can say there are few tumor cells outside as well, right? Cancer is what? If your handwriting is ugly, it will become much better looking like a cancer, right? So I can draw an intestinal type, I can draw a diffuse type if you want to represent in the form of a diagram. I'm not a person who's going to look for a diagram, but most of you feel that diagrams get you mark, right? If you feel the diagram is going to get you mark, simple representation, tell mark these are Zygote ring morphology, understandably clear, and you can say it's an intracytoplasmic mucin present here. And I can say here, these are malignant gastric glands. Because of the pleomorphism and high NC ratio, we have malignant glands here. Marker is not required to diagnose gastric adenocarcinoma if at all asked. IHC CK7 positive in both intestinal and diffuse type. And when you go to prognosis, diffuse type of carcinoma will have a poor prognosis. Because of the early spread, they have a poor prognosis here. Fine. Okay. True, right, Snehit? Handwriting bad, it looks ugly any which way. So cancers are any which way ugly for us, right? Okay. Treatment, you can write gastrectomy or an neoadjuvant chemotherapy with surgery. See, the term neoadjuvant chemotherapy with surgery will fit in for almost every cancer what you're going to write. That's the like a template treatment. Give a chemotherapy, reduce the size of the tumor, and remove it, right? And you can write based on the TNM staging, I'll do a partial gastrectomy or a full gastrectomy. Same for your colon, hemicolectomy or a total colectomy based on TNM staging. Same for the breast, complete mastectomy or a lobectomy or a quadrantectomy, right? Simple. Based on the stage, treatment always differs, but by default, treatment is going to be, the first line of treatment is going to be surgical removal, fine? Okay. Same thing, let's go and have a look at colonic cancers as well. So same risk factor, colonic cancers, these two are must to write. When you go to the pathogenesis, we have to explain in detail about both H and PCC as well as in familial adenomatous polyposis, fine? Okay. And sporadic etiology is just to add on the fuel to the fire. Sporadic etiology is a combination of these both, low fiber diet as well as high fatty foods, smoked food, alcohol, and also, right, any chronic inflammatory disease. When I say chronic inflammatory disease, one disease which I particularly have to talk about is IBD. IBD, be it an ulcerative colitis or a Crohn's disease, will definitely increase the risk factor of colonic carcinomas, right? Syndromic, like I said, these two are must to write. But if it's a long answer, you might definitely have a subtype of the LAQ asking, tell me about colonic polyposis syndrome. Right? These are like template syndromes, FAP and HNPC. In addition to that, we have lots of colonic polyposis. Can anyone give me any other syndromes which you know with respect to colonic polyposis? I'm coming to the Rishi. Not just Peutz-Jeghers, right? There are lots and lots of colonic polyposis syndrome. Whatever comes to your mind, you tell me. Peutz-Jeghers is one. We'll start with whatever Rishi said, right? Rishi, see, reading before the class helps us to revise topics as well, right? All of you, please do that. Tomorrow, I'll be talking about liver, breast cancers, and about a few things about female genital tract. Fine. There are lots of them, starting with juvenile polyposis. So juvenile polyposis is to start with. Juvenile polyposis, you have SMAD4 gene mutation. Along with the polyps, you might have also increased risk of pancreatic adenocarcinoma here, fine. Okay, you'll have both gastric and pancreatic carcinomas. Then Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, mutation in STK11 gene. What are the things in Peutz-Jeghers syndrome? Apart from your colonic tumors, gastric tumors, you'll also have polyps are different, polyposis are different, fine. Okay, so Geshta. I'm talking about polyposis syndromes, not the polyps. Polyps are your villus tubular and everything. That is like a precursor lesion. Polypos, that will come in the adenoma carcinoma sequence, fine. Here you'll have gastric. It will also increase colonic. It will also increase pancreatic. In addition to that, there is an oral finding, which is great, Tushar. Perioral melanosis, perfect, like whatever Sheetal said. Mucocutaneous pigmentation or perioral melanosis is more of a scientific terminology, fine. All the best, Tushar. Read well and tell to your juniors to read well. Okay. Then we have Cowden syndrome. Cowden is your P10 hematomatous syndrome, right? So involves P10 mutation. Cowden syndrome is something which you must read in endometrial cancers as well. So colon, endometrium is a common link there. Fine. That's one, right? I do have classical FAP. In addition to classical FAP, if it's a long answer, please expand the other types of FAP as well, fine? So if it's a long answer, I want you to write the classic FAP. The way to identify classic FAP is the APC gene mutation with minimum 100 polyps. I'll write the rest of the FAP. I want you guys to tell the answer, fine? When will you call it an attenuated FAP? When will you call it a Turcot syndrome? When will you call it a Gardner syndrome? Fine. All of these are variants of FAP only. Clip shot, Hindi, I am trying clip shot. Hopefully next year. Fine. Attenuated is, I should have minimum of or approximately 30 polyps. Plus APC mutation, I'll call it an attenuated FAP, right? Perfect. Turcot syndrome, Gardner syndrome. A easy way to remember, Gardner is going to work with the hands, right? So skin and bone lesions are Gardners. Something pricks in the skin and the bone, like Gardner. It's polyps plus osteomas and skin lesions. Turcot is brain. Polyp plus CNS tumors, medulloblastomas, gliomas, I'll think of a Turcot syndrome, right? So these are variants of FAP. All these are must in syndromes when it's a long answer, right? Okay, that's all, Rishan. I don't think you will get colonic cancer in a short answer unless your examiner wants to really screw up with your time. Colonic cancers are generally long answer questions. And what will be the clinical history for colonic cancer? Most important history will be an elderly person, iron deficiency anemia, occult blood in the stool. That will be how the most of the time colonic cancer will present, along with a little bit of mucus in the stool and altered bowel habits. We'll look them when you go to clinical features, fine? Okay. So we know quite a good thing about syndromes. Whenever you explain the syndromes, you need not explain everything, but don't miss FAP and HNPC. Those are two basic things for us required to explain in case of a colonic adenocarcinoma pathogenesis, right? So here let's write FAP here. This side let's write HNPCC related or your Lynch syndrome related. Okay. So FAP is a problem in APC. So APC loss will result in excess beta catenin, right? So if you want to write, give a hint about the adenoma carcinoma sequence, that this becomes that slowly with more and more and more mucosal problem, more and more mutation, the entire tumor becomes very big, right? So, or if it's an APC loss, the first thing is a germline APC loss where it's completely normal with a beta catenin mutation, or a second APC loss which makes the mucosa at risk. It won't have any lesion here, just a mucosa at risk, that's all. Next, I need a KRAS mutation. KRAS mutation produces a adenoma, results in adenoma. If it's a malignancy related adenoma, most often a villous adenoma, right? In addition to that, when you have TP53 and your SMAD4, those things are acquired, which becomes a dysplastic lesion or slowly becomes carcinomatous. And carcinoma, obviously the terminal one is same guy, telomerase. Last one to go is telomerase loss. It becomes very, very, very aggressive and it will become metastatic. Fine. So this is a simple adenoma to carcinoma sequence. You have an adenoma and slowly becoming a carcinoma. Adenoma carcinoma sequence was first discovered in your colonic tumors. So we'll have to write about that. Perfect, Rishi. Great. If you can remember the adenoma carcinoma sequence, amazing. For every tumor, we have adenoma carcinoma sequence. Few things are standard. Telomere is always the last. First is the genetics, what you read. Before becoming cancer, add P53 because that's the most common gene mutated. Some way or the other, it will come inside, right? Few things I can easily remember. In between, you have to write the other important genes as well, right? Great. So let's come to Lynch syndrome. Lynch, like you guys said, is a mismatch repair defect. Okay, it's a DNA mismatch repair defect is what Lynch syndrome is, right? Lynch syndrome also has adenoma carcinoma. So when you have a mismatch repair defect, so there are few genes, MSH, MLH gene mutations causes mismatch repair. So whenever this gene are gone, I will not be able to properly repair the DNAs. So what happens is I'll have lots and lots and lots of new mutations. It's not one here. It can be multiple here, right? This increases or accumulates more mutations. I cannot pinpoint, okay, this only should undergo mutation. Anything can come. So here from normal colon, so this adenoma carcinoma sequence goes a little bit differently. Let's say from a mucosa at risk, it moves to a type of adenoma. These are called as serrated adenoma. It's the same, but the morphology is different. But in FAP, I'll have villous adenoma or tubular adenoma sometimes, mostly villous adenoma only, right? Then I'll have one of the few mutations which progresses them to a cancer. Same, TGF beta, BRAF. Don't forget BRAF here. BRAF and TGF beta mutation pushes them to malignancy. Okay. Makes them carcinomatous. Fine, right? And finally, always we'll have the same guy, telomerase. Telomerase loss will undergo metastasis. Fine, okay. Why borders are serrating? See, why borders are serrating? I'll give you a very simple example to relate it. Imagine I'm having a normal cell. Mutation causes a cancer growing like this. But here the problem is not one mutation. The problem is I'm not having mutation, the mismatch repair is not happening properly. So you can have a mutation here, 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 everywhere. So it grows like that. It grows like a tree which is not cut everywhere. If I cut, it grows in one direction. If I don't cut, wherever I have mutation, it grows. So it kind of looks like serrated. Fine. They're also both only. Rishang, they're also both only. The inherited is one, sporadic is always seconds. Two-hit hypothesis will be there in both, but in colonic tumors, we have well explained that's all. Fine. Okay, perfect. So we know the pathogenesis. Etiology, write in detail if it's a 10 mark. If it's a 5 mark, stick to APC and your HNPC. That's more than enough. Pathogenesis, obviously, you have to write whatever it is, 10 mark or 5 mark, right? Now, clinical features. Symptom of colonic cancer most of the time will be this. elderly with an iron deficiency anemia, it can be a question which can relate to your hematology and also your colonic pathology. Fine. Okay. Fine. So altered bowel habits is nothing but altered constipation and diarrhea. That's what I mean by altered bowel habits. For a couple of months, they'll be constipated. Suddenly, there'll be diarrhea. Again, after a few months, constipated. It's not normal, that's all. Altered bowel habits sometimes can have mucus also, but the most important symptom is this. So, whenever an elderly presents occult blood in the stool, which means the cancer in the colon is bleeding very, very, very lightly. It bleeds, but bleeds like 0.1, 0.2 ml of blood per day. I can't see them in the naked eye. It's occult blood in the stool, right? Occult blood is something which is not visible to the naked eye, right? That is the most common symptom of almost every colonic adenocarcinoma. Please don't get swayed to hematology because there's an iron deficiency anemia there. Elderly, IDA, occult blood in stool, think of a colonic adenocarcinoma. If it's a long answer, this history will be there. Advanced stage, like always, I'll have loss of weight and loss of appetite by default, fine? So when you do a colonoscopy, the investigation is obviously colonoscopy. So colonoscopy can give me multiple things. It can help me to differentiate whether it's a polyp or a polyposis. It can help me to differentiate site of the lesion, whether it's a right side lesion or a left side lesion. Right side lesion mostly will be associated with a Lynch syndrome. Fine. Again, Rishank, see, we have discussed multiple times, Rishank. It's not a line. I cannot draw a cancer from point A to point B. It's point A, I'm having a mutation. It's a mucosa at risk. Without adding more things, more mutations, it will not grow faster to become a cancer. Maybe it will cause cancer very, very slowly. Cancer is not due to a single mutation. Any cancer is due to multi-step only. What adenoma carcinoma sequence tells us is, I'm describing the multi-step pathogenesis, that's all, fine? Okay, left most likely due to APC beta-catenin mutation, fine? Great. Sessile pedunculated also it can tell me, but it's generally for a polyp. For a carcinoma, it might not help me much about that, fine? Okay, when it come to gross, I have two types of gross pathology. Same like before, I can have an ulceroproliferative mass or I can have a infiltrative mass, right? So ulceroproliferative mass, you can draw a colon. You can say it's a proliferating mass here as an ulcerative here, completely blocking it, right? Fine. Sometimes the carcinoma of the distal colon can form a ring-like lesion, right? So a proximal colon mostly can form an exophytic ulcerative mass. A distal colon, right, can generally tend to form annular lesions. Annular lesions are termed as an napkin ring lesions. We've discussed this, what does a napkin ring means, right? When you go to hotel, they might put a ring on a towel. It constricts in the center. Like that, I can have a exophytic mass like this, or I can have a napkin ring lesions, where it's annular. I cannot draw three-dimensional thing here. So it grows from both the sides and throughout. It can form that, right? Or I can have completely infiltrating lesion, where you have thickening of the wall, which might indirectly relate to stricture. It's due to intense desmoplasia, not forming a mass, right? That's the growth for almost every adenocarcinoma involving the hollow viscus. Ipsita, it's not like I cannot define the duration. It's altering. That's what is not a proper bowel habit. Okay. Perfect. So an ulceroproliferative mass and you have an infiltrating mass, right? Microscopy is pretty simple. Whatever may be the type of an adenocarcinoma, microscopy is same. We have the glands, we have the same 4 features of dysplasia. Please, the day before the exam, watch the patterns of neoplasia. It's very, very important for us. Okay. It'll help you to write at least 5-6 words in the microscopy of any cancer. And 4 feats of dysplasia, what we have described in the neoplasia chapter, look at them also. Pleomorphism, high ANC ratio, mitosis, loss of polarity. If you have lots of time, draw all of them beautifully. Put a irregular gland and draw, okay, I'm having a very abnormal cell, line cell. If you don't have time, draw something irregular. Draw something irregular. That's it. Fine. Okay. Microscopy, no. Gross, yes. It's because of the lumen size. That's all. Fine. And also you'll have the same thing. You'll have infiltration into lamina propria. I can call it a malignancy. One extra information. In tumors associated with HNPCC or a Lynch syndrome, there will be a brisk immune response or a brisk lymphocytic response. Okay, if you have a brisk lymphocytic response, I will think of a most likely of a Lynch syndrome. Fine, okay. IHC to say it's colonic tumor, 2 markers, CK20, CDX2, that tells it's from colonic origin. To prove it is HNPCC related, I should have negative for MSH, MLH. Not positive, it's positive, it's normal. If it's not present, then I have the mismatch repair gene absent, so it results in mismatch repair problem, right? Rishi, apple core is same napkin ring in a barium enema. That's all. It's same napkin ring in the barium enema. It looks like an apple core. If you want, let's write that also. This in an barium enema, it looks like an apple core lesion. Okay, got it? That's for your colonic adenocarcinoma. Okay, we saw about gastric and we saw about colonic tumors as well. Fine. Okay, perfect. Guys, can we continue tomorrow? I have not a good thing happening in the family. Someone is sick. I have to go and meet them. I'll cover for sure your colon. I have 2 more questions left in colon. This is your IBD and your peptic ulcer disease, and also with liver pathology. I'll continue tomorrow. Fine. We'll do it a little bit early. I'll ask them to start around 5 p.m. Can we start around 5 p.m. tomorrow? Is that fine? If that's okay with you guys, we'll start by 5. We'll complete that, and also we'll complete this 5 to 8 o'clock. Okay. It's based on the morphology of the colon, Rishank. See, you have different morphology for proximal and distal colon, right? Ideally with the normal anatomy also. Some of them the anatomy favors a throughout spread in a distal colon. It does not favor a throughout spread in a proximal colon. Fine. Okay. Hopefully they'll become well soon. Fine. So we'll start by 5 tomorrow. Sorry for stopping it abruptly. We'll definitely come back tomorrow and complete it in a single go. Fine. Thank you guys. Thank you for understanding. Thank you. Bye-bye.